Hello, I'm Mike Palladini, the host of Addiction Pharmacy Podcast, and welcome to our weekly episode. This week we're going to be talking about medication assisted treatment. Our guest today is Dr. George Lloyd, M.D., a physician with over 30 years of experience. He's certified through the American Society of Addiction Medicine, has an established practice for treating patients with opioid use disorder. He administers detoxification, rehabilitation, and medical maintenance therapy. He's been helping patients with their recovery needs, as I said, for over 30 years, is a colleague and a good friend of mine. Dr. Lloyd has served as a medical director for various programs, treatment programs, over these many years, and brings us a wealth of knowledge to the podcast. So, as a friend and colleague for some time, it's my pleasure to have him on our podcast. Dr. Lloyd, thank you for being with us today. Really appreciate it. I've known you for quite a while. We've worked together with populations in certain areas that we've both worked. You've been working with the opioid use disorder patient population for quite a while, so I'm glad to have your expertise and experience with us. In your experience for doing opioid use disorder treatment, medications for opioid use disorder treatment for as long as you have, what strikes you overall as something that may have changed in the past 20 or so years when we look at treating individuals with opioid use disorder?
Well, 20 years ago or so, the only real option for medication-assisted treatment for opioid use disorder was methadone. Because abstinence, we have 100 years or more of abstinence-based treatment that is resoundingly unsuccessful pretty much in every patient population with opioid use disorder that's looked at. Now, saying that, there's a couple that have done a little bit better than that with abstinence-based treatment for this disorder, which are basically airline pilots and physicians. The thing there is there's a heavy external motivator, their license, and they're tightly monitored for a period of 5 years for their initial contract. And a part of the contract includes intensive treatment for a good portion of that 5 years. And anyway, so those people tend to do fairly well with abstinence-based treatment. The rest of the patients don't. And that's why in the 70s, I believe, or late 60s, they came out with methadone, which was opioid agonist that actually, there's a lot of evidence that shows that it saves lives. It helps reduce a lot of the negative aspects of opioid use disorder, decreases disease, decreases recidivism, decreases mortality. And as you may be familiar with, methadone is very highly regulated. Typically, it's a clinic. You go every day for a long period of time. Then if your screens are good and everything checks out, you're not missing visits, then you may get take-homes for a period of time. But usually that's still limited to about a week in Pennsylvania. Other states, it's a little bit more liberal. I think Maryland goes up to a month. But this still wasn't very available to a lot of people with opioid use disorder. And that's why in the early 2000s, they came out with Suboxone, buprenorphine plus naloxone. And the idea was that it would be able to be used to treat people with this disorder from a doctor's office setting, to try to bring people with this disease more into the mainstream than they had been in the past. So you're not relegated to, a clinic that's on maybe the edge of town, and all the people with this disorder go to the clinic. And so this enabled people to go to doctors' offices. The buprenorphine, according to DEA scheduling, is a Schedule 3 drug as opposed to methadone, which is a Schedule 2. Until this law, which was, I think it's referred to as Data 2000, which allowed physicians to treat people with opiate use disorder with Suboxone from their office. Prior to that, there was no opioid options for people with this to be treated from a doctor's office.
Yeah, I know now that, as we refer to this as office-based outpatient treatment, or OBOT, as opposed to the opioid treatment programs, or the OTPs of the past that were utilizing methadone. The goal was to just make treatment more available to more people in an expanding geographical area.
And to bring treatment more into the mainstream.
Sure, as well.
So the idea would be you go to your family doctor or your PCP, and he's able to prescribe this medication that is effective in decreasing your relapsing back into, using other opioids.
I believe there's still some resistance there in bringing this medication and the recognition of opioid use disorder and these medications for it into primary care practice or into some healthcare systems where,
yes.
As yourself being a specialist, there's still this reference to the specialists need to handle this. And then as we follow the disease of addiction model, do you think that there's a certain level of expertise that's necessary when treating people appropriately and reaching that successful point?
Yes. I think a lot of people would be managed well from their primary care doc, people that are highly motivated and are able to take it as prescribed, consistently have drug screens that are negative for other drugs of abuse and positive for buprenorphine. Some problems with that. I've talked to a lot of docs who have gotten the waiver. They took the course and got the waiver, the X register for a DEA number to be able to prescribe Suboxone. And they never prescribed Suboxone. I asked them why. And common things were they basically said they're afraid of the kind of patients it would attract. They're afraid that they would be disruptive and they would be off-putting to the other patients in the practice. And I understand their concern. And what I tell them is you're already getting those patients. They're the guys coming back for a refill on their Percocet 6 months after their sprained ankle that's still on Percocet. And so, a lot of primary care docs and even other docs, psychiatrists, they're not familiar with having the person take a urine, maybe even observing the urine to make sure it's their urine. Things like that. And actually, to manage it well, especially early on for a lot of the patients, you kind of have to get your hands dirty. You have to spend some time talking to them about, where do they live? Who do they live with? Are they still hanging out with the same people that they were using with? And are you actually going to treatment? A good place to start as an outpatient is IOP. And are you going to IOP? And did you sign a release with the therapist so I can call the therapist just to make sure you're showing up? Things like that, and it's time consuming. And a lot of the docs and nurse practitioners and PAs, I don't feel are, for one reason or another, likely to do that. And so in that case, if you have someone that's on Suboxone and they're not doing well. They're continuing to use, or their counts are off and they're calling for early fills and things like that. I think those people should be referred to somebody maybe that's a little more specialized in it. If it's somebody that just, took to it, they're taking their medicine as best you can tell, as prescribed, okay, then they don't need a specialist. I believe everyone benefits from some level of treatment, especially early on, because usually by the time someone arrives at a Suboxone clinic or a Suboxone provider's office, I would say there's a lot more going wrong in their life than just the substance they're using.
Yeah, good points, Dr. Lloyd. The disease model helps us understand quite a bit about what someone might be going through, but it's so multifaceted that there's many other aspects of their life that have contributed and that need to be monitored and helped with, as well as their physiological state. One other thing, with the opioid epidemic, or the prevalence of opioids for so long now, only natural that we're seeing more concentrated forms of opioid, and fentanyl being the main substance that's in the illicit, the drug use. Do you notice any changes in your therapy and what might be needed because the dependence of these individuals has gotten to the point of it is because of fentanyl use?
Well, fentanyl is behind the continual increase in opioid overdose deaths. It even shows up in other areas. You'll have pressed fentanyl being sold as Xanax. And so people that aren't even intending to use opioids are coming across fentanyl and overdosing and dying. So that's different than it was 10, 15 years ago. Another difference is nowadays it's much harder to get someone from fentanyl to Suboxone as an outpatient. Back before the fentanyl, when it was heroin, I would get this is my typical call. I get a call from a guy looking for Suboxone, and he's injecting heroin, and I would say, okay, don't use after midnight tonight. I'll see you in the office tomorrow at 10 a.m. and I'll test your urine, I'll check your ID, and if everything looks right, I'll start you on Suboxone. And I would start them on Suboxone, give them they would call it an induction, give them the first dose in my office and watch them take it. And it would be smooth. By midday that day, they would be fine. They'd feel normal. They would not have any withdrawal, and they wouldn't be sick. Nowadays, with the fentanyl, you have to wait longer, typically about 40 hours after their last use before you can safely start Suboxone. And even then, you need to go low and slow. Don't give them 8, give them 2. And it takes 2 hours to fully kick in. And once you have a total of 4 milligrams successfully in someone, they're pretty much home free, and you can give them the Suboxone without worrying about precipitating withdrawal. Mm-hmm. So that's a big difference. And there's different analogs of fentanyl floating around, where some you can easily start them at 36 hours. Others, you give them a dose at 48 hours and they precipitate withdrawal. And from not just the dip cards, but even sending them out, which you wouldn't have that back in time, it doesn't differentiate one from the other necessarily. Like it'll say yes or no if it's carfentanil, but there's still other analogs of fentanyl that have their own peculiarities as far as half-life and things like that. So it really makes it harder to start someone on Suboxone as an outpatient these days. Now, there's medications you could give them to temporize it for the next 24, 48 hours and then start them. However, as an outpatient, it's very unsuccessful. The pull is too strong. That you'll put them on these other medicines, and then somewhere in the middle, they'll use fentanyl again, you know? So the best way, if you have the option, I would say go to detox. And that way they can keep you comfortable. You're in a monitored setting, and you don't have the option of using fentanyl, not unless you leave the detox. And you can actually get induced onto buprenorphine and then go from there. And then you start to have some options. You can stay on, the films or the tablets. You can consider getting the Suboxone shot, which is a once-a-month shot of buprenorphine. It's subcutaneous. Or if you decide you want, one off everything, you can try Vivitrol, which is opioid antagonist, and it actually decreases your urge for opiates. One good thing, especially with the fentanyl, is you can start methadone right on top of your fentanyl. And, again, it would help if you were motivated, because you're going to start out at like 25 milligrams. So it's going to take, some time to get you up to a dose that's kind of therapeutic and helps you not use fentanyl. But the good thing there is they can dose you right on top. And it's especially useful for pregnant women because you don't want them to go through withdrawal, because you really don't know what it's going to do to the fetus. So, that methadone is the only FDA approved drug for pregnant women with opioid use disorder.
That's a lot of challenges there with induction, and I realize that. And the point being of having someone in an inpatient program to detox, that also kind of aligns their motivation a little better and removes the triggers and the temptations away from someone who may be trying to do it on an outpatient basis, because that's a significant time frame for somebody to achieve abstinence before they can start utilizing a drug like buprenorphine.
It's hard.
Yeah, all due to the fact that this fentanyl type of drug lasts that long and is hard to get out of the system.
Yes.
Thank you. A lot of great thoughts there. I appreciate all of your input, Dr. Lloyd. I hope to have some folks listen to us and give us some feedback, and formulate some more questions, and then hopefully find another opportunity to talk with you and address additional concerns and topics when it comes to opioids and M.A.T.
Thank you, Michael.
All right, thank you. Thank you, Dr. Lloyd. Appreciate you for sharing that information with us on our podcast. It's good stuff, hopefully of some value to all of our listeners. We hope to revisit this discussion at a future date and continue to learn more about medication-assisted treatment, as well as helping those with opioid use disorder. Remember, post your comments and questions under the podcast here. I'd like you all to subscribe and like our Addiction Pharmacy channel, and we can then notify you of any future podcasts coming and help you to understand a little bit more about these issues. Again, thank you to Dr. Lloyd, and we hope to see you again.